Hello, everybody. It's a great pleasure to have another global Immunotalk today. I'd like to say hello to everybody around the world. Hola, bonjour, guten tag, namaste, ni hao, konnichiwa, aloha, shalom, and Mihai, how would you say it in Romania?
Well, we say salut.
Salute. So thank you so much. I'm Susan Keck from the Salk Institute, and it's a great pleasure to have our speaker today, Mihai Netea. Mihai has been a long-standing leader in the field of innate immunology and our understanding of inflammation and chronic inflammation. He was born and studied medicine in Romania. I'm probably going to butcher the city. He completed his PhD at Radboud University in the Netherlands and studied sepsis and cytokine networks, and then went to do his postdoc at the University of Colorado, where he then returned to Nijmegen, where he finished his clinical training in infectious diseases. And now he heads the Division of Experimental Medicine in the Department of Internal Medicine at Nijmegen University. He's mainly interested in understanding what he's really been a major influential thinker and conceptual thinker in the field has been in not just thinking about the adaptive immune system for having memory, but the innate immune system as well, and understanding the effects that the innate immune cells, particularly macrophages, undergo when they are exposed to pathogens and inflammatory mediators, and how they undergo epigenetic reprogramming that leads to their functional states, a process that Dr. Netea described as trained immunity, and has a profound impact in our thinking of how tissues and innate immune cells in general sustain inflammatory states and its impact on chronic infection. Sepsis has been a major area that Dr. Netea has been studying, BCG vaccination, and more recently in COVID as well, of course, and understanding the impacts of the severe inflammatory diseases. He's been a recipient of many awards, the Spinoza Prize in 2016. He's an ERC endowed awardee, and he is a member of the Netherlands Royal Academy of Sciences. And more recently, he had a really interesting study as well on not just how innate immune cells can maintain memory of their past experiences, but how this can actually perhaps also be transmitted across generations as a form of inflammatory memory. And so it's a great pleasure to have you share with us your ideas today. And as we normally ask one question to our to help the field know a little bit more about yourself, one question we wanted to ask you was, being an immigrant yourself, what advice would you give to a young scientist who is training abroad?
Well, first of all, thank you very much for the kind invitation. It's an honor and a pleasure to be together with you today. And regarding that, yes, indeed, I moved from Romania to the Netherlands when I finished medical school. And well, it is tough when you go outside of your comfort zone and outside of the comfort of the social network of the family who supports you and so on. So it is always tougher to be somewhere else, but on the other hand is also very stimulating. And I think that one of the most important things that we can as individuals is to be positive and to see the good part of things, of the new experience that we have and of the new things. There is always adversity in life, and some things happen sometimes, but I think the most important thing that we can do, and also as scientists, to not see these as or see ourselves as victims, but just to understand, well, sometimes things happen, and to see beyond them and to be optimistic and to work hard for what you dream. And in the end, I am convinced in the vast majority of times things get better and things go well. So to remain optimistic, I think it's very important. And Yes.
Yeah. Yeah. And even in times of need, to know you've got support wherever you are, right?
Absolutely.
Yeah.
Absolutely.
Great. Well, thank you. So we are going to let you share your screen and go ahead and start your talk.
Yes. I hope you can see my screen now.
We can. Yep.
Fantastic. So thank you very much once again for the invitation. And I would like to share with you today some of our work in which we try to understand what are the adaptive characteristics that can be built in innate host responses. And this can be a little bit paradoxical because for a long time we have learned from our immunology books that actually only adaptive immune responses can adapt, only lymphocytes, B cell, T cells can adapt. But we started to be interested actually in a little bit more than that, how are innate immune responses adapting? Because we were working on mycobacteria, on tuberculosis, and we were working also on BCG. And we stumbled across some very old studies, and later on also some newer studies, but they described actually something very strange. They described that when BCG was introduced in various countries around the world, and this is one of the first studies describing this in 1932 in Sweden, BCG administration in the young children significantly decreased overall mortality, decreased it by 50% or even more than that. You can see here from 11% to 4% in the first 4 years of life. We have to understand this is before the antibiotics have been developed. But this could not be explained by the decrease in the tuberculosis deaths. The BCG was protecting against tuberculosis also, but tuberculosis could be responsible only for maybe less than 1% actually of the deaths in these children, whereas the protection was decreasing from 11 to 4%. So it has been hypothesized by the doctors observing that. This was Carl Näslund, responsible for the introduction of BCG in Sweden in those years, that BCG must provoke a sort of non-specific immunity and improving the resistance to infections. And this has been observed many times when BCG was introduced in different countries. And this is a systematic review performed by a WHO SAGE group, who has reported actually that in many studies, both observational studies, but also a number of clinical trials, the BCG decreased overall mortality more than that can be explained by tuberculosis deaths alone. So apparently BCG is able to protect actually against other types of infections, against overall mortality beyond tuberculosis. So how can that work? First of all, we thought, okay, this seems to be observed in epidemiological studies, but can we demonstrate that this is the case if we use a controlled model of infections in humans? And for that, what we have done is to mimic an infection. Of course, we cannot infect healthy individuals with something dangerous, but we can use, for example, a vaccine which is with an attenuated microorganism, and we use for that yellow fever vaccine because that induces a mild infection. And in case of the yellow fever vaccine, we can also assess the viremia in the circulation of the vaccinated individuals. Basically, we get for approximately 5 to 7 days a very mild viremia in our circulation after vaccination. And what we did is in 2 groups of healthy individuals, one group received placebo, one group received BCG, and then we vaccinated all of them 1 month later with a yellow fever vaccine. And we assessed the viremia in the circulation. And what we have observed, well, on day 3 and day 7, very few people had viremia. But on day 5, when the majority of the people had viruses in their circulation, people who received BCG had significantly less virus particles in their circulation compared with people who received 1 month earlier placebo. And you can observe here, this is a logarithmic scale. Importantly, this was not associated with a decrease in the yellow fever antibody titers. That was perfectly fine 90 days after vaccination with yellow fever virus. So basically what these studies demonstrated was that vaccinating people with BCG can decrease the microorganism load Of course, in our case, with a very mild type of infection, but this was done in a heterologous fashion. So BCG was protecting against a viral infection. Now, how can we explain that? Because if we would explain that by T cells and B cells, which are antigen dependent, we cannot explain this very heterologous effect. So we thought, would it be possible that innate immune cells, which are non-specific, which recognize pathogen through pattern recognition receptors, but this is not antigen specific, would it be possible that their function is also modulated by BCG? So what we did in another study is we asked people to get a BCG vaccination and to donate some blood before the BCG vaccination, 2 weeks later and 3 months later. Then we purified innate immune cells. In our case, we purified first monocytes, and we stimulated them both with Mycobacterium tuberculosis, let's say a microorganism which is close to Mycobacterium bovis, but also with very different microorganisms, Staphylococcus aureus and Candida albicans. And what we have observed is that the cytokine production capacity after stimulation with all three microorganisms was increased after BCG vaccination, showing that basically that the function of the monocytes changed after the BCG vaccination. Now, how can we explain that? And because all these data are published, I'm just now summarizing the results of a couple of years of experiments. What we have observed is that there are changes in the way that the epigenetic regulation of gene transcription is taking place before and after vaccination. And we talk about this regulation in innate immune cells. So, for example, if you have an innate immune cell, such as monocyte or a macrophage, and it is before an infection or before activation by a vaccine, in the places of the genes which are necessary for host defense, the chromatin is tightly packaged because there is no gene transcription needed, and the transcription factors do not need to bind to the promoters to induce gene transcription. However, if we activate this macrophage by an infection or a vaccine, we induce changes, chemical changes in the histones, in the nucleosomes of the chromatin, acetylation, phosphorylation, methylation, and so on. That results in a relaxation of the chromatin, allowing the transcription factors to bind to the promoters to induce gene transcription and to produce cytokines, defensins, whatever the organism is needing during an infection. Now, after the infection is eliminated, we always thought, well, these chemical changes are lost, chromatin will get back to the normal conformation, the gene transcription stops. And partially this is true because gene transcription does stop because we don't need now cytokines and defensins and all these proteins. And the chromatin architecture does go back to normal. But this change is not completely back to what it was before, because some of these chemical changes in the histones remain. It's like closing a book, but putting a bookmark at the right page that you want to read. So if you want to read, how can I defend myself against an infection? You put the sign at the right page that you, at the next infection, you can open the book much quicker and read much easier. You don't need to look, well, where was the page 243? No, you have now the bookmark there. You open the book directly and you can respond much quicker and stronger to the reinfection. And importantly, this whole process is antigen independent. It does not depend on a specific antigen. It just depends on the proper activation of the cell. This leads subsequently to an improved function of some of these innate immune cells, and this induces an increased resistance to the reinfection. And this, again, is not against the same infection. It can be also a different infection the secondary time, provided that these genes that were necessary for the first infections are necessary also for the defense against the second infection. Because if that is not the case, we cannot defend ourselves better the second time. And this is important when we will go to discuss a little bit more about COVID-19. Now, what are these places? Where are we putting the bookmarks? Well, we don't put the bookmark in one place. It's not only one page that we need in case of an infection. We need many proteins, so we put a lot of bookmarks. So actually, in order to do that, we have performed a whole genome assessment of chromatin marks, of open chromatin. We have looked at 3 chromatin marks, monomethylation of lysine 4 of histone 3, H3K4 monomethylation, then the trimethylation of the same mark, H3K4 trimethylation, and H3K27 acetylation. And we assessed which are the places where we put these bookmarks. And when we assessed actually through pathoanalysis these genes that were epigenetically changed, we have observed a lot of genes which are important for host defense, integrins, inflammation, cytokines, toll-like receptors, and so on. But at the same time, very importantly, we observed also important epigenetic changes in genes which are important for cellular metabolism, glycolysis, oxidative phosphorylation, amino acid metabolisms, vitamin D, and so on. So again, I'm summarizing then data from a couple of years of experiments. What we have observed, basically what is happening in these cells, is a strong interaction between metabolic processes and epigenetic long-term reprogramming upon immunological signaling. What do I mean by that? This is an example with beta-glucan, but with BCG is happening the same. Pattern recognition receptors are activated, certain intracellular signaling pathways are activated. One of the most important is ACT-PI3 kinase, activating mTOR. And mTOR is a hub for regulating cellular metabolism. What we observed, there is an increase in glycolysis, but at the same time, there are also changes in TCA cycle. The TCA cycle is no longer used catabolically to produce ATP, but it's used anabolically. Citrate is extracting, forming acetyl-CoA in the cytoplasm. Acetyl-CoA is used on the one hand for histone acetylation by histone acetyl transferases, but at the same time is used for lipid synthesis and cholesterol synthesis. And one of the intermediary metabolites in the cholesterol synthesis, mevalonate, is released and acting on the IGF-1 receptors to actually amplify these effects. Now, TCA cycle is also changing with accumulation of fumarate, and that was very interesting to see, because fumarate is one of the important TCA cycle metabolites which modulates epigenetic enzymes. Basically, it inhibits KDM5 histone demethylases. So by accumulating fumarate, we inhibit the histone demethylases, so the methyl groups are allowed to persist on the histones and in the nucleosomes, which is allowing for these bookmarks to stay in place. At the same time, there are also activation of certain non-coding RNAs, especially low no-coding RNAs, which serve also as transporters for certain methyltransferases, and that is also important for the entire methylation process. So in the entirety, we have modulation of immunological signaling, interaction, and changes in cellular metabolism, and the cellular metabolites interact and activate or modulate epigenetic enzymes to result in this long-term epigenetic programming of the cells. Now, this is very nice, and we have observed that in the circulation after the BCG vaccination. But something is a little bit strange, because if we take after 2 weeks or 3 months monocytes and we assess their function and their epigenetic programs and so on, how can they be different? Because monocytes are generally in the circulation maybe for 1, 2, maximum 3 days. So how is it possible that we give the vaccine on day 0 and then we see still changes in the monocytes on day 14 or day 19, when there are completely different monocytes, because these are new monocytes coming from bone marrow? Now, the only way that we can explain that was our hypothesis, is that these changes that I described to you at the level of function, at the level of transcriptional changes, epigenetic changes, would take place also in the bone marrow progenitors of these innate immune cells. So for this, to demonstrate whether this is the case, we performed a study in which we vaccinated the BCG, and we vaccinated healthy volunteers with BCG or with placebo. And then we asked the volunteers to donate not only blood, but also bone marrow aspirate, and they kindly did so. And we assessed the immunological function, and we see immunological function in the periphery and in the bone marrow. But very important thereafter, we purified the hematopoietic stem cells from the BCG vaccinated individuals, both before and after BCG vaccination. And at 90 days after BCG vaccination, there is no BCG in the skin or in the bone marrow or in the circulation of these persons. And we assess that and we check that. Despite this, the transcriptional and epigenetic program of these hematopoietic stem cells is drastically changed. So there is a very strong bias towards myelopoiesis and activation of myeloid cells in the program of these hematopoietic stem cells, meaning that these hematopoietic stem cells can lead to the release of daughter cells in the circulation even after 3 months with a completely different transcriptional and functional profile. And we observed actually that granulopoiesis was strongly increased. So at that point we thought, well, we never checked the function of the granulocytes because we thought, well, these are end differentiation cells. It's very difficult to modify their function long-term with BCG. But then we thought, well, granulopoiesis apparently is changed. So would it be possible that the function of granulocytes is also changed after BCG vaccination? And in a follow-up study, we did precisely that. We purified granulocytes after the BCG vaccination, and we assessed their function. We assessed IL-8 release, it was increased. We assessed the release of elastase, it was increased. Elastase and other proteinases, very important for host defense mechanisms. We assessed also the killing capacity of Candida albicans, and it was increased also. The reactive oxygen species production was increased. The net formation was not. So net formation activation was similar. So that function of the neutrophil was not increased, but all the other function were improved after BCG vaccination. We also assessed epigenetically the neutrophils. We have observed again increased markers of open chromatin, H3K4/3 methylation in genes important for activation of these cells, IL-6, TNF, IL-1 beta, also in some genes important for cellular metabolisms, mTOR and phosphofructokinase. And very almost strange, I would say, because of the low number of the volunteers that we had for these epigenetic changes. These epigenetic changes actually associated with the killing capacity of the neutrophils, even with these low numbers. But this demonstrated basically that changes at the level of the hematopoietic bone marrow progenitors induced by BCG long-term changes not only the function of monocytes, but also the function of granulocytes in the volunteers. Now, we have this data regarding, well, immunological function and so on, and we have also several, actually a lot of epidemiological studies, especially in children, showing this protection of the children against all types of infections and against mortality. But what about adults? And when we got all these types of data, suddenly COVID-19 pandemic came. And we knew actually, and basically on the yellow fever study, we had the hypothesis already that the viremia in the circulation of an individual would depend actually of the strength of the innate immune response. I showed you in the beginning of my talk the data regarding yellow fever, vaccine viremia. So basically the hypothesis would be if somebody has low innate immune responses in the beginning when they are home and they don't even know that they are infected. If we don't respond properly in the beginning, the virus has the chance to grow. It induces high viremia. This is inducing high inflammation in the periphery. That can induce also high severity of a disease. And in the case of a severe disease, such as influenza or COVID-19, that can lead to even to death. Whereas if somebody has high innate immune responses in the beginning, that leads to low viral load, low systemic inflammation, low system cell survival. So we thought, well, if this model would be true, can we maybe protect people against infections in general and COVID-19 in particular now during the pandemic? Now, first of all, we started a study. Actually, we started it just before the pandemic at the end of 2018, and then we followed the people for 1 year till the beginning of 2020, actually, just at the moment that the pandemic hit us. And these were elderly who were in the hospital for some other disease. And we know that the elderly, when they are hospitalized, when they are going home, actually, they are immunocompromised. They have a high susceptibility to infection. They have very high rate of infection when they go home. So we wanted to see, can we protect them at least partially if we vaccinate them with BCG at the moment that they go home after being recovered from their hospitalization. And we performed the study, ACTIVATE study, together with the colleagues from the group of Evangelos Gavarelos at the University of Athens, in which elderly who were going home after hospitalization received placebo or BCG. We followed them for 1 year, and we observed that they indeed had 40% less infections. So that was very promising. We were getting the data exactly at the beginning of the pandemic. At the same time, some other people hypothesized the same. Maybe administration of BCG can protect against SARS-CoV-2 infection. And this is a beautiful mouse study published by the group of Alan Scher. Was done during the pandemic, and he also observed that administering BCG was able to protect the mice. Now, there is a problem here also. He observed this protection only when given BCG intravenously, not when giving it subcutaneously. But then, of course, we had our epidemiological studies also in children done by other people and our data. So we started several BCG vaccination studies during COVID-19. First of all, we did the same study again in Greece with BCG revaccination. And I'm saying revaccination because this is a population in Greece who received BCG already at birth. So they were vaccinated once again when they were had an age higher than 60, so they were elderly. And then we followed them up for 6 months, and then indeed we have seen a lower number of COVID-19 infections. This was a small study, so we thought, okay, let's do a large study. Let's do a study in the Netherlands where we do not have BCG at birth, and we just vaccinate for the first time elderly individuals. And we have done BCG-Prime study in the Netherlands, 6,000 individuals, 3,000 got BCG, 3,000 didn't receive BCG, and we assessed COVID-19 during the first 6 months, and we have seen absolutely no difference. So the total number of infections, COVID-19 infections in BCG vaccinated individuals were precisely the same in this population who received for the first time BCG. Okay, we thought, well, it is what it is. We would have loved to see an effect, but we were not able to see it. But how do the people react to the SARS-CoV-2 infection if they are vaccinated with BCG or they received placebo previously? So we assessed both the cellular immune responses and the serological immune responses. And very interestingly, when we assessed that, we have observed actually that both cellular immune responses, but also the serology, was better in the individuals who received previously BCG compared with the placebo receiving individuals. So we thought, okay, we cannot protect against the total number of infections, but can we protect against the severity of the disease? And then we analyzed the severity of the disease, COVID-19 related admissions. So the severity, now we look only at the severe COVID-19, and we see a 15% decrease in the COVID-19 related admissions in the BCG group. We did not reach statistical significance, very important to say. Interestingly enough, when we looked at that, we have looked also at influenza-related related infection, and there we did see a 50% reduction. That was significantly different, very interesting, and that was reproducing our data that we observed before the COVID-19 pandemic, when most of the infections were obviously not COVID-19, but influenza. Now, finally, we thought, okay, let's look at the real severe cases of COVID-19, people who die. So we looked at the overall mortality in our study, BCG-Prime. You can see here in the middle of the table, we have seen 18 deaths in the placebo, 13 deaths in the BCG, an approximately 13% reduction, but not statistically significant because we did not reach it, because we didn't have the numbers. Fortunately, it's better that the people did not die. But still, when we saw that, then we asked all our colleagues around the world who have done BCG studies to provide us with their overall mortality data to see whether if we do summary statistics, we see a difference. And as you can see here, in all the 5 studies that reported actually mortality during the BCG study interval, in all of them, there was less mortality in the BCG group compared with a placebo. None of them reached statistical significance because none of them were powered to do that. But then when we performed summary statistics, we have seen actually approximately 40% less mortality in the BCG group, and that was statistically significant. Now, important to say, none of these studies were powered to do that. This is observational data, putting together all things, but it is suggestive, of course, that BCG at least probably protected against mortality and against very severe infections. Now, not only BCG, BCG has been reported in the literature to obtain this decrease in overall mortality, but also other vaccines that contain attenuated microorganisms. And one of that is measles containing vaccines. This is again systematic review that was published by the WHO SAGE group, the same as the BCG in British Medical Journal in 2016, and you can observe here also decreased mortality in the studies assessing the effects of measles containing vaccines, MMR, for example, or MR. And we wanted to know, is it only BCG which is inducing these heterologous effects, having this immunological function and so on, or can we observe this also with a measles-containing vaccine? So we perform a proof of principle clinical trial in which we now vaccinated people with MMR and not with BCG, and we assessed again the same thing that we did previously. We looked at the number of cells, number of monocytes, number of neutrophils, no effect. Then we looked at the function, and we thought, okay, with BCG, we also don't see many differences in the cell numbers, but we do see very clear difference in the cell function. But now when we stimulated monocytes from the MMR vaccinated individuals with various stimuli, and we assessed cytokine production, there was absolutely no difference. So the function of the monocyte was completely normal. So we thought, okay, so that's not how it works apparently. So how can we learn? We don't know at which cells should we look. So then we said, okay, let's perform single cell sequencing and assess which are the cell types in which we see most of the differences after the MMR vaccination. And to our surprise, the cells in which we saw by far the most differences were the gamma delta T cells. And gamma delta T cells are innate-like type of cells, also being activated in a more antigen-independent way. And we see very clear changes after MMR vaccination and not after placebo in the gamma delta T cells. So then we thought, okay, is the function of gamma delta T cells also now different if we stimulate them? And we develop assays for stimulation of gamma delta T cells. We purify them, we stimulated them, and indeed we see a significant increase in their capacity of producing cytokines such as TNF and interferon gamma. When we looked at the cellular metabolism with the SANIT methodology, which looks at the various metabolic pathways at the single cell level, we have observed that the V gamma delta 2 cells have no dependency on glucose. It was not not similar actually with what we have seen in the monocytes, but they were using higher fatty oxidation after the MMR vaccination. So there was again a change in the cellular metabolism, but not in the glycolysis, but in the fatty acid oxidation. So based on that, and we are now assessing in depth what is happening with the function of gamma delta T cells, how do they work, and so on. But what we observe is that in case of another vaccine that induces heterologous effects, like MMR vaccine, there is again a non-specific heterologous effects, but through another type of mechanism, through changes in gamma delta T cells and changes in their metabolic processes and in their function and the capacity of secreting cytokines. Now, other people have done also observational studies with MMR vaccines, and in COVID-19, this is actually a randomized placebo trial with MMR done in Brazil. And what people have observed actually is again no difference in the total cases of COVID-19 in the MMR group or the placebo group, but the symptomatic patients and the patients who needed treatment and hospitalization, there was a significant decrease in the MMR group compared with the placebo group, more or less similar with what we see in case of the BCG. So no effect on the total infection, but lower severity of the disease. Well, based on these data on BCG and on MMR, we can conclude that these type of vaccines that induce these heterologous responses that we call trained immunity, they can have potential beneficial effects in case of a new infection. In our case, it was not in terms of decreasing the total number of infections, but in decreasing the severity of the infection. And one possibility would be in the future, in a new pandemic, no longer in COVID-19, now we don't need it, we have specific vaccines, which always work better than these heterologous effects. But in case of a new infection, when we do not have a new vaccine, we can perform very quickly phase 3 clinical trial. And if we see effects after 3 or 4 months in doing a large enough clinical trials, we can provide bridge vaccination with such trained immunity inducing vaccines in the population to induce partial protection, to decrease severity of the disease and mortality until we develop and implement a new specific vaccine. Now, in the last couple of minutes of my talk, I would like to share with you some data that go beyond the infections. So we have looked during the last years to see whether similar type of epigenetic, metabolic, and functional reprogramming can take place also in other types of diseases than infections. And we have observed actually that there is an inappropriate induction of trained immunity in autoimmune disorders, cardiovascular disease, in gout, rheumatoid arthritis, and so on. And their trained immunity inhibition might be very useful. And we also have seen actually that defects in induction of trained immunity and activation of innate immune responses can take place not only in infections but also in cancers. And I would like to give you 2 examples on how can we manipulate these and hopefully in the future treat patients for improved outcome. So the example of cancer, for example, there are several mouse studies showing this, but we have performed also a study in humans in which we assess the function of hematopoietic stem cells in the myeloid, in the bone marrow compartment of cancer cells, in this case thyroid cancer patients, but we are doing the same now in colorectal cancer patients. And what we have observed actually that the myeloid multipotent progenitors of the patients are decreased. There is a defect in myelopoiesis, and also the function of these cells is decreased in patients with thyroid cancer. Very interestingly, these can partially improve after surgery and radioactive iodine. But now I want to go one step beyond and ask, can we use induction of trained immunity, changing in the bone marrow progenitors and in the phenotype of the myeloid cells to improve the outcome of cancer in experimental models of cancer. And we took as a model, again, BCG. BCG is used, for example, in bladder cancer, but it cannot be used in other types of cancer because it's a live microorganism. We cannot give it IV, so to treat lung cancer or breast cancer and so on. We can give it in bladder cancer because we give it externally basically through bladder instillations. But still, we can learn from BCG with its anti-tumoral effect to learn which component of the surface of the cell wall of mycobacteria induces these activation processes, induces strain immunity, and to incorporate that component in new medicines. And I'm not going to present all the data because we don't have the time, but to make a long story short, this is the mycobacterial cell wall, and we tested all these components from the mycobacterial cell wall for induction of strain immunity, and we identified that muramyl dipeptide component from the peptidoglycans of the mycobacteria can induce strain immunity in an in vitro model, but also in vivo models. And then we thought, okay, can we apply that? Can we construct basically an artificial BCG, let's say, that contains muramyl dipeptide and muramyl tripeptide to induce strain immunity and can be safely administered, so not disseminate in our patient, not give an infection, but can be safely administered. And we started collaborating with a group of Willem Mulder from the Mount Sinai Medical School in New York, who's an expert in nanobiologics. And he has a beautiful model in which he used the HDL molecules as a natural nanoparticle, and he built an HDL particle which was decorated and on the surface with muramyl dipeptide and muramyl tripeptide. We tested it in strain immunity inducing assays, and it's inducing very nice strain immunity. And then we used it in animal models. First of all, we wanted to see, does it go to the bone marrow to reprogram the bone marrow? Yes, it does. You can see here very nicely, this is zirconium labeled particle. You can see how nicely it distributes, not only in the liver, all the nanoparticles go into the liver, but also at the level of bone marrow. At the same time, it's going very clearly here. You can see the target tissue, and it's going also to the tumor. Very important because it's taken up also by the tumor-associated macrophages. And then we started to treat. We used, this is the example of B6 melanoma model, but we have also models of breast cancer, pancreatic cancer, and lung cancer, and the same thing is happening. We start treatment 1 week after inoculation of the tumor, and you can observe here with increasing dosages of the nanoparticles that induce strain immunity, we see actually decreasing the growth of the tumor. We can also induce strain immunity in the bone marrow. We can transplant the hematopoietic stem cells in another mouse and then do the tumor inoculation. And you can see actually that we can transmit the resistance through hematopoietic stem cell transplantation. And the transplanted mouse is more resistant to the tumor. We can also reproduce these data in REG1 deficient mice, which do not have functional T and B cells. So we do see effect also only if we activate the myeloid cells, but it's not working as good as in the normal mice, meaning that there must be a collaboration and intersection in between the function of myeloid cells and lymphoid cells. And that is logical because, of course, the myeloid cells which are activated can activate thereafter also the lymphoid cells. So we hypothesize if we activate at the same time the myeloid cells, we reprogram the tumor-associated macrophages and the bone marrow from being immunosuppressive to being anti-tumoral. Let's combine it with checkpoint inhibitors, which specifically activate also the T cells. And very importantly, this is a model in which checkpoint inhibitors don't work. You can see here actually the growth of the tumor, and checkpoint inhibitors don't have any effect here. However, when we give nanobiologics, which induce strain immunity, again, the tumor grows slower. But when we combine the two checkpoint inhibitors with the nanobiologics, we observe very strong inhibition of the growth of the tumor. Actually, in half of the mice, the tumor completely disappeared, meaning that we actually likely have a beneficial effect if we combine activation of T cells with checkpoint inhibitors and reprogramming of myeloid cells by trained immunity inducing agents. And now we are developing these nanoparticles for human use. So hopefully in, well, the next 1.5 to 2 years, we can do similar studies in humans. Finally, in the last 2 or 3 minutes, I would like to say, well, trained immunity is nice, and it's important for host defense against infections. It's important to treat cancer, but it can be also inappropriately activated and induce inflammatory diseases and autoimmunity. And there is a lot of data now in the literature suggesting that this is indeed the case. And we were interested also to know, well, can we also identify ways in which to decrease and modulate trained immunity, and hopefully in the future use that for treatment? And I'm just giving you one example. We try to see whether classical anti-inflammatory cytokines such as IL-10 and IL-4 can decrease trained immunity, and hopefully in the future be used. What we have seen actually is that indeed IL-10, which is very strongly inhibiting pro-inflammatory cytokine production, which is known for a long time, does that, but also does inhibit also induction of trained immunity. We used a model of trained immunity in vitro, in which beta-glucan upregulated the cytokine production capacity induced by LPS, and we can inhibit that with interleukin-10. Now, the surprise came when we used actually interleukin-4, because interleukin-4 is known to inhibit acute stimulation of cytokines, and that went very nicely. But then when we assessed the capacity of interleukin-4 to inhibit trained immunity, it was not able to inhibit it. And interestingly enough, if we exposed for a short period of time the isolated monocytes to recombinant interleukin-4, then we let them rest, and then we re-stimulated the classical trained immunity protocol, we observed that IL-4 itself was able to induce trained immunity. So on the one hand, it inhibited acute inflammation, but it induced and improved cellular responsiveness. How is that possible? Well, we know that IL-4 receptor acts through 2 different pathways. On the one hand, through PI3 kinase and mTOR pathway, and on the other hand, through STAT6 pathway. And we hypothesized maybe these 2 pathways have different functions, and indeed that was the case. When we inhibit STAT6 pathway, we inhibited the downregulating function of the IL-4 on acute inflammation. However, when we inhibited STAT6, we had no effect on the trained immunity effects of IL-4. The opposite was true for the PI3 kinase mTOR pathway. It did not affect the acute inflammatory pathways, the inhibition of acute inflammation by IL-4, but it inhibited the capacity of the IL-4 to induce trained immunity. You can see here inhibition of mTOR with taurine-1. Strongly inhibited the induction of trained immunity by IL-4, but it did not affect the acute inflammation. So all in all, it seems that these different pathways of going through IL-4 receptors, on the one hand, induce inhibition of acute inflammation, but it induces an improved responsiveness on long term. That could be important also in vivo, because we have situations such as sepsis, which are characterized at the same time by hyperinflammation and poor responsiveness to secondary infections. And we wanted to develop a method to be able to use IL-4 in vivo. Why don't we use simply recombinant IL-4? Because the biodistribution is very bad. You can see when we administered a recombinant IL-4 to the mice, it just went to the kidneys and it was immediately eliminated. So what we did, we built a fusion protein containing ApoA1, which is the component of the HDL, together with recombinant IL-4, and we built basically nanoparticles of HDL containing recombinant IL-4, and they have now a much better distribution also into the lymphoid organs, activating also immune cells in the spleen and in the bone marrow. And using that, we want now to go into situations such as sepsis, very severe infections which are associated at the same time by acute phase hyperinflammation and immunoparalysis. And as a proof of concept, we have done that with cells isolated either from individuals who received LPS in vivo intravenously, and that induced a form of immunoparalysis, basically, and we were able to salvage their immune function by this recombinant, nanobiologic containing recombinant IL-4, or in a model of ex vivo tolerance, in which we induced ex vivo tolerance by LPS exposure of cells, and restimulation can no longer activate the cells, because LPS induces strong tolerance, and we rescued that with a nanoparticle containing IL-4. And in the future, we want to develop these nanoparticles actually also for inhibition of acute inflammation, but at the same time, improvement of the responsiveness of cells towards infections. So all in all, what I wanted to show you today is that there are changes that take place after an infection and after certain stimuli, not only in adaptive immune cells and lymphocytes, but these changes can also take place in innate immune cells. I talked especially about the monocytes, also a little bit about gamma delta T cells. Other colleagues of us have shown also NK cell memory, and these changes are determined by epigenetic reprogramming of the cells. I showed you data on histone modifications, but there are also data in the literature showing the role of DNA methylation and of the long no-coding RNAs. These changes are leading actually to, are meant to lead to adaptive states to protect us either against hyperinflammation by, for example, mucosal tolerance, or by training programs to maturate the innate immune cells to improve the protection against infections. But in certain cases, it can lead also to maladaptive states, for example, immune dysregulation in cancer, or hyperinflammation in atherosclerosis or other inflammatory diseases. And we hope through modulation of these processes in the future to improve the outcome of these diseases. And finally, of course, I would like to thank all the colleagues of us who worked on these studies in our laboratory, but also in the Department of Molecular Biology, with whom we did a lot of epigenetics in our universities, and all colleagues around the world who collaborated with us in our studies. Thank you very much. I think I don't hear you at least. I cannot hear you.
I don't think Lou's audio is working, but to ask questions, you guys can just go to our Twitter, find the tweet that says "Ask Dr. Mihai Netea questions here," and respond to that tweet with your questions, and he will be responding using the ImmunoSpeaker account. Thanks everyone for coming, and we'll see you next week.
Yeah, thank you, Mihai.
Thank you.
Thanks, Stu.
Thank you. Thank you.
Good to see you.
Thank you very much. Nice to see you. Thank you very much.